The organizers again for inviting me here. So I think, can we roll? So this is submuscular plating. I think there's already been some talk about it, that this is for the length unstable fractures of femur. And okay, is it rolling? Okay, so the submuscular plate is basically used for the length unstable fractures in the comminuted long spiral, also for proximal and distal metaphyseal fractures, sometimes where nailing doesn't work so well. And here we have this child, he's a 13-year CP GM-FCS5, fell off the bed, it's a fresh injury, it's a long spiral fracture. This is how it looks in the operating room under image intensification, and the child is positioned on the regular table. For the kids in which the hip is not dislocated, you can put them on a fracture table and it's easier. And you pull it out to length to see whether it lines up, and you need an assistant to help you with that. And once you find that the fracture is lined up, you take a locking plate and you have to choose an adequate length of the plate. So here we took about a 12-hole 4.5 locking compression plate. The incision was marked about 2 inches proximal to the fracture, and that's where it is. And once you mark the incision, you slide a long periosteal elevator, something like in a MIPO set, and hold the plate with the locking sleeve, and you can slide the plate down along the shaft of the femur. So this is the track being made with the periosteal elevator, just under the vastus lateralis. And then you hold the plate with the locking sleeve and slide it down, and you image it distally. And once you have got it lined up with the shaft distally, then you can localize the hole. There are some small locking holes in the plate to transfix them with the K-wire. So here we put in a sleeve to manipulate the plate, and then fixed it with a K-wire, and then drilled a hole and fixed it with a screw distally. Now once the plate has been fixed distally, then you can manipulate the fragment proximally, and here we put a lever and try to get the fragment close to the plate. And once the plate was well aligned, then we again transfix the plate with a K-wire, and then you put in your screws with the locking sleeve. So that's the locking sleeve trying to push the plate onto the shaft. And then you drill and you put a cortical screw which actually pulls the shaft onto the plate approximately. And this is checking the final alignment. And once you're happy with the final alignment, then you can go ahead and put some extra screws proximally and distally. And that kind of finalizes your construct. Okay, I think that's towards the end. So that's looking at the construct, and the fracture looks fairly aligned here. And so this is the final post-op X-ray. So went on to healing, and these are the incision marks that you can get away with. I think, thank you. That's the